Let's get started today with a recap of the last episode. So we first talked about the organization of the ankle foot. The ankle joint is that talocrural joint. The rear foot, that is the calcaneus and the talus. Our midfoot is the navicular, cuboid, and those cuneiforms. And finally, the forefoot, metatarsals plus phalanges. The talocrural joint is a synovial hinge joint, so therefore its primary motions are in the sagittal plane, dorsiflexion, toes up, plantar flexion, toes down. That subtalar joint has three different plane joints between the anterior, middle, and posterior facets of the inferior talus and the superior calcaneus. It allows for triplanar motion of inversion, eversion, frontal plane, dorsiflexion, plantar flexion, sagittal plane, and ab and adduction, transverse plane. We then moved forward to the transverse tarsal joint. That is a compound joint consisting of the talonavicular joint and the calcaneocuboid joint. This transverse tarsal joint complex modulates foot rigidity. Therefore, it unlocks in pronation to allow that midfoot and that forefoot to be flexible, and it locks in supination, which makes that midfoot, forefoot more rigid for push-off. So the forefoot is really there for load distribution. We talked about the rays, with the first ray being the most important, so that medial side. It is really there to contact the ground first, and it allows for that windlass mechanism, which is tension on that plantar aponeurosis, which allows for foot rigidity during that push-off. Finally, I talked a little bit about arthrokinematics, especially of that talocrural joint. Remember, we have a convex talus moving on a concave distal tibia and fibula. Therefore, with dorsiflexion, you get an anterior roll and then a posterior glide. So your mobilizations for dorsiflexion will be a posterior glide. Plantar flexion, opposite. Posterior roll, anterior glide. So your mobilizations to improve plantar flexion would be an anterior glide of that talus on that distal tibia and fibula. We talked about those lateral collateral ligaments, with the ATFL being the most commonly sprained as they resist that inversion. The ATFL inversion plus plantar flexion, and then the calcaneofibular and that posterior talofibular being more of a restriction during dorsiflexion. Then we talked about the medial ligaments, those deltoid ligaments that resist eversion. Remember, they're very strong, so they're not often injured.